I think it's 11 o'clock.
Yes, it's 11 o'clock. The YouTube stream is set, so
Okay.
we can. We're both live on Zoom and on YouTube.
So should we record it to the
Yes,
cloud?
I think this is recording automatically.
Oh, okay.
Yes, so the session is being recorded automatically. It's also being broadcasted live on YouTube. Okay, so it's 11 o'clock, and we'll start now. Dr. Farouk, and Dr. Guru, are we ready to start? Can we go ahead?
Yes, we're ready.
Okay. Thank you very much. Good morning, everybody. Good morning, YOs, and good morning, Nigeria and the world, wherever you're looking at us. This is the crowning event of the World Glaucoma Week celebration for 2021 of the Young Ophthalmologist Forum. Today, we'll be discussing, taking a look at the general theme of the World Glaucoma Week celebration. The word is bright, safe sight. And to do this, we've got two seasoned ophthalmologists to take us through the preliminary steps in assessing a patient with glaucoma. We're going to be having two discussions, one, target pressure, and assessing a new patient with glaucoma. We thought this was important because we won't be able to do anything about glaucoma if we don't tackle intraocular pressure and we don't properly evaluate the patient. Thankfully enough, on Wednesday, the glaucoma toolkit for Sub-Saharan West Africa was launched, and the toolkit contains a lot of goodies for the glaucoma specialists in Sub-Saharan Africa, which is going to make glaucoma care, streamline glaucoma care, and make glaucoma care easier for the glaucoma specialists practicing a low resource and resource constrained environment like Nigeria. The glaucoma toolkit has a lot of tools, which include first clinic evaluation, follow-up evaluations, glaucoma damage, disc damage likelihood score, and a lot of other things which help evaluating a glaucoma patient at first visit and follow-up easier. The toolkit provides algorithms for care and also talks briefly on what we need to do when we have patients with glaucoma. And so it's fitting that we are ending the World Glaucoma Week by starting our glaucoma series for 2021. And we're starting with evaluating a patient for glaucoma and selecting or estimate or getting a target pressure set for our patients. To take us through today's session, we've got two glaucoma specialists who have been practicing glaucoma for a while and are seasoned glaucoma surgeons. We've got Dr. Farouk Garuba from the Ahmadu Bello University of Zaria. He's a consultant ophthalmologist and a lecturer in the Ahmadu Bello University. He is a fellow of the West African College of Surgeons and Nigerian Provincial Medical College of Nigeria, and he's also a World Glaucoma Association and the International Council of Ophthalmology Fellow for 2017. The World Glaucoma Association is an advocacy group for glaucoma care worldwide, and they are actually the brainchild behind the World Glaucoma Week. I want to welcome Dr. Farouk Garuba for today's presentation. We also have Dr. Ogunro Adunola. She's a senior consultant of the Eye Foundation Hospitals. She's a glaucoma specialist, a seasoned trainer. I've been opportune to have attended not one, not two, not three of her training sessions, both at OSN, AGMs, and even at Novartis or any pharma-sponsored training in Eye Foundation. I can tell you that she knows her onions, and she has a knack for stepping down training. She finished from the UCH Ibadan in 1986 with an MBS. She's a fellow of the West African College of Surgeons. She's a Glaucoma Institute fellow. This was in 2002. She's an AROVO host researcher. She also won an AROVO Research Award in 2008 and also had a glaucoma fellowship with Prof. Robert Rich at the New York Eye and Ear Infirmary at 2011. She's the medical director, Eye Foundation Hospital, Lekki Phase 2. So we've got 2 seasoned glaucoma specialists, and we're hoping to get a better idea of glaucoma today. And without further ado, we'll be starting with the first topic, evaluating a glaucoma patient, and I'll be handing over the show to Dr. Farouk Garba. Dr. Farouk Garba, you're welcome, please.
Thank you very much, Dr. Ogu. Hello, can you hear me?
Yes, we can hear you very well.
All right. Okay, let me share the slides. Okay, good morning, everybody. Welcome to this episode of the Young Ophthalmologist Forum. And I know we have had a very busy glaucoma week. We have been seeing the pictures and the advocacy that we have been doing. I want to commend everybody on doing that. So today I will be taking a glaucoma suspect, which is a way of evaluating a new patient, because the moment you see a patient with you think has glaucoma, he or she is now a suspect. And then you do some certain investigation before you conclude whether that patient has glaucoma or not. So I'll be taking it through this short outline. So the cases of glaucoma in hospitals are just the tip of the iceberg. In 2020, 76 million people were estimated to be blind from glaucoma worldwide. And by 2040, it has been estimated that more than 111 people will also be blind from glaucoma. And the majority of these individuals will have open angle glaucoma. And that is the main challenge, because most cases of the angle closure, they are sort of straightforward because of their presentation. So it's mostly the open angle glaucoma and the NTGs, that's the normal tension glaucoma, that we have a lot of challenges in the diagnosis. So it has been said that 50 to 90%, some studies have shown to be undiagnosed. And then the reason for this undiagnosis include lack of knowledge from the part of the community and also from healthcare providers, and poor access to healthcare facilities. Because after we talk on radio and TV and we send out flyers, people want to actually come for screening. But because of poor access to these health facilities, they are now constrained. Then there is also physician-related factors, which leads to failure to diagnose glaucoma. For example, our family physicians, they come to ophthalmology for training. But to be honest, how many of them can confidently do a fundoscopy to assess the disc and now even think whether the patient has glaucoma to send for further evaluation? So improper training is there, and then lack of experience and also poor instrumentation. And then to play the devil's advocate, conversely, we also have patients who have been started on anti-glaucoma medications, but did not meet the criteria of glaucoma. So, and we know labeling somebody to have glaucoma is a lifelong disease, so we have to be careful on that. So the reason for overdiagnosis, fear that the patient may lose vision, because if I'm not too sure, I would like to err on the side of caution. So physicians tend to commence patient on medication, even if they are not 100% sure. And then also, people are afraid of medical legal suits. It's better to start them than, because if they lose vision, eventually it will now become a problem. And then fear of incompetence. Some physicians are afraid that if the patient goes to the next hospital, he might be diagnosed, and then he would say that he's from another hospital, that they missed it. So who is a glaucoma suspect? So we define it as a person who has one or more clinical features and or risk factors which increase the possibility of developing glaucomatous optic nerve damage and visual deficiency in the future. So how do we identify this individual? Mostly, we get our patients from routine, either ocular or non-ocular conditions. They come to the hospital for simple allergic conjunctivitis, refractive errors, and that. And some individuals, actually, we screen them because their families have this glaucoma and they present. Some, they even accompany the families to the hospital, and then we just look at their eyes and we just see something that is suspicious. And then population-based studies. Before the advent of this COVID, which this time around we weren't able to go to schools, organizations to actually screen, do mass screening. But in the past, when we do that, we pick a lot of individuals with who are glaucoma suspects. So when you get these individuals, what is the next step? The first thing is history taking, like any other disease, and we have been taught to be very, very thorough when taking history. Leave no stone unturned, because you have to be fully convinced and also convince your patient at the end of all your evaluations. So you have to ask history of risk factors of primary open angle glaucoma, first degree relations, additional history of trauma, and then sometimes we miss to ask history of steroids. For example, in the northern part, we have a lot of patients with allergic conjunctivitis and they have been on steroids for a very long time. So you have to ask them whether they have been using that. Then when evaluating for normal tension glaucoma, review risk factors such as migraine headaches, hypertension, peripheral vasospasm, sleep apnea, and Raynaud's phenomenon. In glaucoma suspects, having a history of retinal vein occlusion should be regarded to have an additional risk factor. Refractive errors should be assessed in all glaucoma suspects. A number of epidemiological studies have shown that a positive association of POAG with the increase in the degree of myopic refraction. So after taking a thorough history, the next thing is now to start assessing the patient. The first thing you do is your intraocular pressure assessment. Accurate IOP measurement remains central to the evaluation of glaucoma suspect, as maximum untreated IOP and IOP fluctuations have been correlated to glaucoma progressions. Goldman applanation tonometry, rather than handheld, has been shown to be the gold standard. So we should always try as much as possible to use our Goldman applanation tonometry for assessment. And then when assessing IOP, we should be mindful of some subtle things like posture of the patient, breath holding, and then squeezing the eyelid when taking the pressure. And also patient wearing tight neck collars and all that can tend to give us a false high pressure. And then also technique of the physician. You should make sure that your Myers, the fluorescein Myers, are of the right size. And also avoid putting digital pressure on the globe, because you can get high pressure while taking your pressure. So it is very important to establish the intraocular pressure, which we will hear how to assess target pressure from the next presenter. So you need to phase your patient, which could be 24-hour phasing or afternoon phasing. You also need to do the water drinking test to assess, because in my years of experience, I have actually diagnosed patients from this water drinking test. Then measuring IOP in sitting and also supine position, because we are trying as much as possible to establish a certain amount of pressure in these individuals. In absence of other features of glaucoma, if IOP is found to be consistently high on 3 consecutive examinations, then a diagnosis of ocular hypertension can be made. Hence, diagnosis of ocular hypertension is one of exclusion after ruling out other features of POH. So the next thing we do, we have to do a detailed anterior chamber angle assessment and the anterior segment examination. A careful slit-line examination can be useful in identifying diseases such as pigment dispersion syndrome, exfoliative syndrome, which might lead to the secondary glaucomas. So other features like iris transillumination, phacodenesis should all be established. The gold standard of angle examination remains gonioscopy, especially the use of our 4-mirror lenses, which allow dynamic indentation. You have to assess fully and make sure all the angles are open and there is no any pathology. Then additional diagnostic tools, such as our anterior segment optical coherence tomography, can be supplementary but not necessary in routine evaluation of glaucoma suspects. Optic nerve head assessment is a key element in evaluation of glaucoma suspect and also for monitoring progression. That is why our clinical examination is the main factor, because other things are basically supplementary. So determining the cup disc ratio, particularly the vertical cup disc ratio, is very, very important. We have to document. Also, photographs help in assessing the patient objectively and also for future reference. And stereoscopic evaluation of the optic disc have shown a Gaussian distribution of the mean CDR of at 0.4, with only an approximately 5% normal population having CDRs of 0.7. So we see individuals sometimes with cup disc ratio of 0.7, and then we are now worried, is it glaucoma or not glaucoma? So studies have shown about 5% of them could be normal. A difference of 0.2, cup disc ratio of 0.2 between the two eyes should be viewed with suspicion. Such a finding is present in only 1% of the population. So when you have a difference of more than 0.2 between the two eyes in a patient, then that patient is a strong suspect. Studies have shown that both cup and palo enlarge slightly with age. However, the age-related enlargement of the optic cup is gradual compared to the rapid progression you see in glaucoma cases. While in physiologic cupping, despite high CDR, the size of the cups bilaterally are nearly symmetrical. So this table shows the mechanical signs and vascular signs that you see at the cup. So the mechanical size, large cup, large optic cup, asymmetric cup, progressive enlargement of the cup, narrowing, notching are some of the things that you see. Also retinal fiber loss and peripapillary atrophy or crescent. Then vascular signs, disc hemorrhage is very, very important in cases of normal tension glaucoma, which that is the only sign that you see that it's progressing because IOP has been normal all through. Central corneal thickness is measurement has become a routine part of glaucoma evaluation due to the multitude of studies that shows thin corneas associated with glaucomatous progression. The relative risk of POAG increased 81% for every 40 microns thinning of the cornea. So both ocular hypertension and European glaucoma prevention study found that the risk of developing POAG was greater in eyes with CCT less than 555 microns compared with eyes having CCT of 588 microns or greater. Visual field evaluation, we cannot overemphasize the importance of visual field in evaluating glaucoma suspects. So the reference standard for determining the presence of glaucoma remains the SAP, that's the standard automated perimetry, the white on white, preferably the CETA test. There has been evidence suggesting that the frequency doubling technology and short wavelength automated perimetry detect visual field loss earlier than the SAP. So obtain several visual field to assess for reproducibility before making a final diagnosis. So you don't make a diagnosis of glaucoma with only one visual field test. You have to repeat it because we have a problem of learning curve in most of our patients. So preferably you do it within 1 month before the patient forgets all the techniques he used in the first one. And you also consider refractive error when making necessary adjustment if you're getting varying results. And then consider testing one eye at a time because sometimes it's difficult for patients to do the test at a stretch both eyes. So you can do one eye and then schedule the next eye the next day. And also you cannot, for example, if you're checking for progression, you cannot compare apples and oranges. You have to use the same type of machine and the same type of threshold that you use for the previous test. And then okay, and then sorry, some issue here. Okay, supporting imaging. This include confocal laser ophthalmoscopy, scanning laser polarimetry, and OCT. They're also important in helping making the diagnosis. However, they're not readily available in most of our environments. Structural changes such as nerve fiber loss and rim notches often precede perimetric loss and can be measured in glaucoma suspect to determine initial risk and appropriate follow-up. So while objective and quantitative and highly reproducible these technologies are, they should not replace careful and serial examination of our optic nerve head and visual field testing. So after doing all this, now it's time for the verdict. Is the patient guilty of glaucoma or not? So, because you want to determine whether to commence medication, whether to follow up your patient, and how regular do you want to follow this patient up? And then do you want to seek for second opinion? Although we have risk calculators for ocular hypertension treatment study risk calculator, we can actually calculate the risk and to determine whether to, there's the website here, we can all check it and see whether we can, whether it can help us in our clinical practice. But the decision ultimately relies on our clinical judgment. So what do I do in my practice? Actually, if I have a patient that is really neither here nor there, I seek for second opinion from my neighboring colleagues. I send the patient for them to check, or actually all the documents that I have, I actually forward it to them and then hear what they have to say. And if the patient is not really a glaucoma patient at that point, is still a suspect, I review the patient every 3 to 6 months. And if I notice the earliest sign of progression, I then discuss treatment options with the patient. In conclusion, glaucoma suspects are controversial clinical dilemmas. And these individuals have certain risk factors or demonstrate some clinical features suggestive of an increased probability to develop glaucomatous optic atrophy in the future. As the diagnosis of glaucoma is a life-changing condition, which can lead to depression and affect the quality of life of the individual. Caution should be exercised before labeling this individual with this condition. Thank you very much. These are some of the few references.
Thank you very much, Dr. Farouk. So the next discussion will be by Dr. Gunro, and she will be taking us on estimating target pressure. Dr. Gunroma, are you ready for us? Hello, Dr. Ogunro. Okay, thank you. I think she's ready for us now. Okay, I think your microphone is still mute.
My reminder that your microphone and video are off.
Still mute, yeah.
Okay now?
Yes, better now. We can hear you. Thank you very much.
Good afternoon, everyone. And I want to thank the executives of the Young Ophthalmology Forum for inviting me. So I'll just discuss utilizing target pressure for glaucoma care. Treatment in glaucoma management aims to lower intraocular pressure to slow the rate of visual field deterioration. And target intraocular pressure is the upper limit of the intraocular pressure estimated to be safe for the optic nerve to maintain vision-related quality of life in the expected lifetime of the patient. It should be reevaluated regularly when progression of disease is noticed or when ocular or systemic comorbidities develop. Target intraocular pressure cannot be generalized, but individualized for each eye. There are factors that are considered when setting the target pressure. These include the stage of the glaucoma. The greater the pre-existing glaucoma damage, the lower the target intraocular pressure level before treatment. That's the lower the intraocular pressure, the lower the untreated intraocular pressure level, the lower the target intraocular pressure should be. The age and life expectancy of the patient, while in younger age, greater life expectancy is expected and therefore a lower target intraocular pressure in such an individual. Older age is a risk factor for more rapid progression. The side effects and the risk of treatment on the patient, where the patient has much reaction to the treatment, the target pressure may need to be re-evaluated. Patient's preference, depending on the type of treatment he's on. The central corneal thickness must also be considered. Dr. Garba actually discussed much on this. The thinner the corneal thickness, the lower the target intraocular pressure. And the vision status in the new patient. In a newly diagnosed patient, the rate of progression is unknown and target pressure is based on risk factors for progression, like the presence of a severe damage in other eye, family history of blindness from glaucoma, high myopia, ethnicity, which is worse in the blacks, and vascular risk factors. The rate of progression should be used to adjust the target intraocular pressure, taking into account the pressure levels over the observation period, the life expectancy in the patient, and current levels of visual function damage. After sufficient follow-up and with sufficient visual field tests, like 3 to 5 different times that are stable, the importance of the risk factors for decision-making decreases and the importance of measured rate of progression increases. Assessment of the rate of progression of glaucoma damage, that is severity of damage that has already occurred versus time. This chart shows certain, the factors that we consider when setting target intraocular pressure. When the untreated intraocular pressure or at the time of diagnosis is high, then one will need to set the target pressure at higher pressure. And if the incoming pressure is low, the target pressure will be lower. Rate of progression, if it's fast, then the target pressure will be lower. If additional risk factors occur, like hypertension, diabetes, or vascular disease, the target pressure will also be set at lower level. Glaucoma damage, if it's advanced, the target pressure will be lower than when it is at the early stage. The life expectancy, if it's long, like in a younger patient, the target pressure will be lower than when the patient is old. And all these factors will have to be considered as a total in individual person. So this also shows the factors as they affect the setting of target intraocular pressure, the additional risk, the patient's preference, the long life expectancy, fast rate of progression will set the target at a lower pressure. Advanced initial glaucoma damage at presentation will make the target pressure to be at a lower level, and adverse consequences of treatment and the status of the other eye as well. How do we calculate target pressure? Usually in most patients, we want the intraocular pressure to be lower than 21, knowing that we want the intraocular pressure to be between 10 and 21 in most cases. the lower IOP, the pressure can also be lowered by 20% to 30% from the baseline at presentation. And also, it could also be the 1/3 of the baseline intraocular pressure. The formula proposed by John Pell at 1995 AAO is target pressure is equal to initial pressure into 1 minus initial pressure over 100. And this equation was modified in 1999 with taking into consideration the functional status of the optic nerve. And the equation is target pressure is equal to initial pressure, which is the IP, into 1 minus initial pressure over 100 minus Z, where the Z is the functional status. And you have Z0, which is the glaucoma suspect with low risk, Z1, glaucoma suspect with a high risk, the Z2, early glaucoma, the Z3, moderate glaucoma, Z4, severe glaucoma, and Z5, end-stage glaucoma. The classification will depend on the level, classification that we have using the visual field test. The AAO guideline on target intraocular pressure says glaucoma patients with mild damage, that is optic cupping, but no visual field loss, the reduction should be between 20 to 30% from baseline. Glaucoma patients with advanced damage, the reduction will be 40% or more from baseline reduction. And then normal pressure glaucoma or the normal tension glaucoma will have a reduction of 30% from baseline. Ocular hypertension, the target pressure will be with reducing 20% from baseline. Open angle glaucoma with intraocular pressure in the mid to high 20s. The target intraocular pressure range between 14 to 18 millimeters mercury. Advanced glaucoma target intraocular pressure should be lower than 15 millimeter mercury, and ocular hypertension whose pressure is over 30 millimeter mercury with no sign of optic nerve damage, we have the target intraocular pressure lower than 20 millimeter mercury. So at the beginning, one will prescribe the treatment at diagnosis, and the target pressure will be set at the first time. If the patient is stable and the pressure is well controlled, a follow-up of up to 6 months will be allowed, and the patient will need to be followed up normally with a visual field test, monitoring the intraocular pressure and also the patient's condition. If the pressure is not well controlled, or there is progression that is noticed, either from the increase in the cupping or there is more loss in the visual field, then one will consider setting the target pressure at much lower intraocular pressure. And then if the pressure is, if there is no other progression, one will maintain the lower pressure as the target. If there is further progression, there will be need to consider resetting the target and also considering other therapy for this patient. This actually shows the algorithm, of a patient starting medication or therapy with the first choice monotherapy. And if the treatment is well tolerated with effective control of the intraocular pressure at the target intraocular pressure, then the periodic monitoring with the visual field at 6 months, the optic nerve, and the intraocular pressure. If the target pressure is not reached, one will need to add a second drop and then watch for the pressures. If there is progression noticed, one may need to change the second drop to either a combination drop to have effective control of the intraocular pressure, or think about other options like the laser as an additional therapy or offering incisional surgery. So to take home, we need to know that target pressures should be reevaluated periodically, because a target intraocular pressure that is appropriate when you first see a patient may not be safe pressure. Patients may develop new systemic or ocular conditions that may affect the risk or benefit ratio of therapy. Target pressure needs to be lowered if glaucomatous damage is progressing despite intraocular pressure below the initial set target. The target intraocular pressure range may have to be increased if achieving the target intraocular pressure causes adverse ocular or systemic side effects. There is no one target pressure that's appropriate for every patient. It's a
Okay, it seems Dr. Oguro is having some technical issues. Okay, I think we had some technical issues towards the end, but I think thankfully that was the end of the discussion. Dr. Oguro, are you still with us?
Yes, please. Can you hear me?
Okay, thank you very much. Yes, we can hear you. We can hear you. We are worried that we lost you due to technical issues. We are happy that you're still with us. Thank you very much for that presentation. I want to also thank Dr. Farouk for the presentation. Dr. Farouk took us on a journey on evaluating a glaucoma suspect. He told us that all patients be coming to the clinic to be until we have examined and discovered that they are not, they do not have glaucoma or did not need to be further evaluated for glaucoma. He is also harped on the need to collaborate and discuss with your colleagues, especially when we are not sure, so that we don't overdiagnose patients because of fear or of incompetence or legal and medical legal reasons. Dr. Guro took us on a little journey, on the journey of target pressure and its relevance in glaucoma care and its use in treatment for patients and determining when we should continue a particular treatment protocol or change tact when we find progression. We'll quickly take questions now. We've got questions from YouTube and questions from the Q&A chat and questions sent to us. I will start. Dr. Baturi will be joining me in this session in taking questions. If he's got questions, he's also going to ask them. Dr. Baturi, are you with us? All right, thank you. I think your mic is mute.
Okay, good morning all.
Yes. So,
thank you for joining us for this session.
Yeah, Dr. Baturi will be joining me for this section. Dr. Farouk, the first question I have here is for you. Dr. Farouk, are you with us?
Yes, I am.
Okay, thank you very much. So the first question, I think this is germane that we start with this. You know, it's true that the fear of overdiagnosis is there because, first of all, we don't want to miss the diagnosis of glaucoma because we know how devastating glaucoma can be to the visual, to the vision of patients and the quality of life following loss of vision. So most times, the fear of overdiagnosis is very, very present. So objectively, how do we reduce overdiagnosis? Do you have any word to put for that?
Yes, I think it's a very valid question, and I think you have captured it when you were summarizing. We just have to be sure. We just have to be sure. For example, if you have a patient, let's say a 25-year-old coming to your clinic with family history of glaucoma and cup disc ratio of 0.5, and is cupped, pressures normal, CVF normal, CCT normal, and you go ahead to do OCT and it's normal. So in that kind of a patient with only one risk factor, you see, you cannot be sure to commence him on medication to label that individual a glaucoma patient. So I think it's better for us to err on the side of caution and label him a suspect and give him a tighter appointment, maybe 3-6 months. So if you repeat the investigations, and for example, like I emphasized on the assessment of the optic nerve head, if the patient comes back after 6 months and you find a cup dysplasia of 0.6, you see, at that point, you have something to fall back on because you are now seeing progression. So you can now lay the options of treatment to this patient. So I think the way to reduce it is to, you have to be sure. If you are not sure, communicate with other colleagues and then arrive at a meaningful diagnosis.
Okay, Dr. Oguruma, what are your thoughts on this question? How do we objectively reduce overdiagnosis of glaucoma in our clinics? Is it something that we can do? Your mic, ma.
Yeah, thank you.
Yeah.
It's very important to reduce the overdiagnosis because it's a life-changing diagnosis for this patient when we think of the quality of life. And this is where the OCT actually comes in handy. OCT will detect the early stage of glaucoma. And in OCT, a large curve or a large curve disc ratio will show whether the large curve is normal or is a defect due to glaucomatous damage. And that puts an end or a diagnosis to it. The OCT will come in very handy.
Yeah, thank you very much, ma. And that brings me to a clinical scenario that has played out more than once. You have a patient who comes to you with who's been on glaucoma medications for the past 3 years, and then you examine this patient, and the patient is a glaucoma suspect, no systemic risk factor. She's not hypertensive, not diabetic. She or he cannot possibly tell you there's a family issue of glaucoma, and she's been on medications for a long time. And OCT puts her at borderline RNFL loss and GCC loss. The question now is, what would you do for this patient? Would you want to continue her on care? Or would you want to withdraw these medications and watch her with OCT and see if she's going to progress? Because we actually don't know who's going to progress. And we actually don't know who's not going to progress. So this patient has been on medications. You don't know if the drugs she's on is what's keeping her from progressing. Or you don't know if she naturally falls into the group of people who would not progress or who just have borderline RNFL changes. What would you do in this situation? Would you take off drugs or would you continue drugs? Or is there any objective way of assessing the need to either continue care or not?
Well, what is most important in this case is to ensure a proper follow-up for this patient. If one has a borderline damage, that means, and the visual field is normal, we are talking about pre-perimetric glaucoma, and we need to explain to the patient, is either you want to continue this medication.
I think we are having some technical challenges from Dr. Ogun's side.
No,
am I?
No, you're on, Maya. Very good. We can hear you very well.
So it's either the patient continues the medication if he wants to, and if you're going to stop the medication, to watch the patient for the level, to be able to establish the rate of progression in this patient. It is important to let the patient know that every year or every 6 months, you need to do your field test, you need to do your OCT every year. And the key is, getting the progression. Glaucoma is something that it's not a one-time diagnosis, but that progression is key. And this lies in follow-up care.
Thank you very much, ma. And Dr. Farouk, that brings me to a question I have here. The question is based on, what's the basis for review of your patients? do you just arbitrarily give all patients 3 months, 6 months, 1 year, or is this review basis tailored to the patient presentation or when you clinical state of patient presentation? And is this review basis based on what you think is a projected RNFL ganglion cell loss? And if it's based on this projected loss, what is the physiologic loss and what is termed pathologic ganglion cell loss on review of these patients? Dr. Farouk?
Yes, thank you for the question. Actually, yes. When I see patients with high cup disc ratio, for example, like the 0.7 above, I try to give them a very tight leash, like mostly 3 months, so that they can come back and I will review the important investigations. However, patients with 0.5, 0.6, I usually dance around 6 months to review them. Now coming to RNFL loss, if I see RNFL loss, that is entirely a different thing, because the moment you see nerve fiber layer loss, it means there is some damage going on, and that patient diagnosis of glaucoma has to be made, because the moment you leave that patient 6 months with no medication, no matter how little the nerve layers he loses, he can never regain them. So you have to take nerve fiber layer loss very, very important.
Okay. Is there a physiologic value or is there a pathologic value to determine severe loss or mild or moderate loss or progression?
Yes.
Do we have OCT values for these?
Yes, we have OCT values. Mostly there is the average value that you see. So an average value of over 100 is actually significant. It's not actually significant,
That's
but any
100
loss,
100 in a year?
No, averagely 100 microns, the thickness.
In a year? Is it annually?
At diagnosis.
Okay.
Yes,
okay.
anything less than 100, you have to commence medication. But anything above 100, you can actually try to observe the patient and see.
Okay. Is there an accepted RNFL progression during glaucoma treatment? We know there's physiologic RNFL loss. Dr. Guru talked about determining progression with target pressure. When you see when we are reviewing these patients, is there an acceptable RNFL loss for us to say, okay, this patient is within acceptable limits, so we don't need to be too worried. We are winning with our team. Let's continue winning with our team. Or is any loss during glaucoma care accepted as progression?
Yes, actually, I think there is a acceptable value, but I don't have the exact value on my head right now. But I think maybe Dr. Guru will help with that question. But I think anything less than 20 microns in a year, I think it's acceptable because that's the normal loss. But I'm not too certain of the value. Yes.
Okay. And Dr. Guru, do you have any input on that?
Yes, like the for the clock hour, using the clock hour assessment for the in the OCT.
Yeah.
It's said that about difference of 10 microns. And the other thing is the OCT nerve fiber layer thickness varied from one machine to the other.
Yeah.
But as Dr. said,
and race too.
And the race as well. So one has to be able to know which machine, what it takes for each machine over time. And then, of course, for the progression, the difference of the 10 microns, and also taking into consideration other factors that could be a risk.
Okay, thank you very much, man. Thank you very much. Yes, we have some questions from the Q&A box. Okay, yeah, one question here says, okay, Dr. Okuru, I think this question is for you. Corrected IOP, how is that calculated? Does it have a role to play in glaucoma management? Because we do know that there are a lot of tables for IOP values following CCT calculation. So what's the role of corrected IOP? Is there a particular way that is universally acceptable for calculation?
Well, for the corrected IOP calculation, there are machines that actually give the adjusted intraocular pressure, difference. And it's important to know this because it helps to set the target as well in a patient, especially if the patient is progressing or if the patient has advanced glaucoma damage. We know that the thin corneas are actually a risk in patients.
Progression.
Yeah. So it's quite important.
Okay, thank you very much, ma'am. But do we, do we have intermachine variabilities in calculation of corrected IOPs? Does this come to play when deciding target pressures? For example, I have a patient who comes in from a facility from the east who had maybe an A-scan pachymetry done, and the corrected IOP was given for him, and then he comes and he's been on medication because of that, and then he comes, and then I have an OCT, maybe a more advanced machine, do a corrected pachymetry and IOP, corrected IOP, and there's a difference. What do I do then? Do I base my findings on clinical findings alone?
Well, there's difference between the OCT and the ones that just the topical,
the contact pachymetry.
Contact CCT measurement.
Yeah.
And then usually the OCT gives somehow a higher value than the contact lens and the contact CCT. And this should be taken into consideration as well. But in all, it's just along the same line that the CCT affects it.
Thank you very much. Emma, don't go yet. And we have another question for you from the Q&A box. So 2 questions actually. First one says, what criteria do we use to classify glaucoma into advanced, moderate, and mild? Is there, what criteria do we use? And then another one says, okay, I think that's for Dr. Farouk. So Ma, this one is for you. What criteria do we use to classify glaucoma into advanced, moderate, and mild?
Well, using the MD, that's the mean deviation, and the PSD. Actually, the mean deviation comes in more handy, which actually groups to, -2 to -4 as the mild or the early, and then -4 to -6, and then above -12, you have the severe glaucoma. So this is actually used for the assessment.
Yeah, and that's gotten from the visual field assessment of the patient.
Yes. Okay. Knowing that the PSD is mainly due to glaucomatous damage and no other additional clinical disease like cataract, because all this also will affect the mean deviation.
Yeah, the mean deviation, yeah. Thank you very much, ma'am. Dr. Farouk, sir, a question here says, for the water drinking tests, how much increase in IOP from the first measured IOP is said to be significant?
Yes, the water drinking test is usually done for patients with normal tension glaucoma, because you are trying as much as possible to establish how high the pressure is. So we usually give 1.5 liters of water, but some studies said you can use 10 mils per kg. But averagely, we give 1.5 liters for individual to ingest over 30 minutes. And then you take the pre-injection of the water IOP, and then you now take the IOP 15 minutes after the completion of taking the 1.5 liters. So every 15 minutes, you now take the pressure. Every 15 minutes, you now take the pressure. So when you have a difference of greater than 6 millimeters of mercury between the first and the last measurement that you take, so it's actually significant. While in some individuals, when the pressure rises above the normal intraocular pressure, that is 21 millimeters of mercury, is also diagnostic. Then sometimes again, during the water drinking test, we do take the pressure sitting and lying in and also supine position again to see if we can get the difference. All this in order to be sure that we are not missing anything.
Okay, thank you very much. And just to stretch the question a little bit further,
Yeah.
what's the basis for doing a water drinking test? Actually, does it have a role in
Yes.
determining aqueous production or aqueous drainage, or does it have a role to tell us that at a point in time during this patient's regular lifestyle, as he moves around during his day, that his pressures are elevated, or is there what's the basis, the importance?
Yeah, I think it all boils down to the increase in the aqueous production. And since you have the limited outflow, so the pressure will definitely rise within that period. So that is the reason why if you have a patient that you're not sure of the pressure, you can actually try that.
Yeah. So that tells us that the patient, even the patient has a normal tension glaucoma at clinic visit, the pressures
Yes.
are normal as the patient is visiting. There are times during the day when these patients' pressures may be above normal and dangerous to the optic nerve, and that will
Exactly.
account for the damage we're seeing on the optic nerve. And so,
Yes.
hence, we need to modulate intraocular pressure. Thank you very much, sir. Dr. Mustafa Baturi, do you have any questions for us? Are there any questions on your end?
Okay, thank you, Mr. President, for this session. I think the presentations has elaborated the need for accurate detection of patients with glaucoma and those that are glaucoma suspects. And the importance of this cannot be overemphasized because there is a lot of cost associated with misdiagnosis of these patients. I remember at center, we saw a patient that had traveled to Egypt, India, a lot of private hospitals, and he was diagnosed with early glaucoma. But finally, there was no element of progression over the years, and he had to stop applying medication. And he has done several tests, and I think is 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 timely for us to know how to detect this, identify these patients early and accurately, and also do the needful. There is one question for Dr. Farouk on the chat. That what is the difference,
Okay.
or what
Yeah,
difference
yeah.
will be? Okay, he has answered that.
No, I think his answer was what spurred this question. I think Dr. Farouk, someone wants to know if there's any difference between prone and supine position IOP measured during the water drinking test. You told us any IOP measurement between pre-ingestion and post-ingestion of greater than 6 milliliters of mercury is significant. I think someone wants to find out if there's any significance in measuring prone and supine positions after the water drinking test.
Yes, IOP has been shown to differ when taking sitting and supine. So that is the reason why when you're also doing the water drinking test, because like I said initially, it's just like the courts. You have a suspect, you are trying to use all necessary evidence to try to make that diagnosis of glaucoma. So we're leaving no stone unturned. So that is the reason, even when you're doing the water drinking test, you want to establish how high does this pressure goes. Because if this pressure, for example, the patient while sitting down, you get something like 18, 19, and the moment this patient lies down and you have a pressure of more than 21 millimeters of mercury, so that could be diagnostic. So that is why it is important to explore all these avenues when checking your intraocular pressure, especially for the normal tension glaucoma patient, because you want to make sure that this pressure actually, because they have progression and you don't have anything to explain why they're having this progression. So that's why we're hammering on this intraocular pressure to make sure you have exhausted all avenues.
Yeah, thank you very much. Just before you take some breath of air, we have some two questions for you again. Okay, one is, what's the role of von Herrick? Does von Herrick have any role to play in assessing a patient or evaluating a patient for glaucoma? And then, if von Herrick doesn't have so much of a role, what gonioscopy technique is preferred, which is reproducible, which gives you a very good idea of what you're doing in the angle, and what would you recommend?
Yes, thank you for the question again. I believe gonioscopy is one of the, it's a very important tool that you find, well, at least people find it difficult to do gonioscopy. And then everybody, sometimes you just put it and then you think it's grade 3 because most of the cases that we have in this part of the world is open angle. So
Open angle, yeah.
It's grade 3. We'll send to the glaucoma unit. If they want, they can recheck and see. So I think the 4 mirror lens is a very, very friendly lens to use on patients because it doesn't need coupling agent. So I find it very, very useful. Put a lot of amiotrocaine and explain the procedure to your patient. Have a very good lid dilatation, lid opening, and then you just simply place your lens. And then I think the 4 mirror is one of the most important lens that we can use. And it actually, I find it patients do cooperate better. So, and if we learn our gonioscopy, when you start all these laser procedures, because you use gonio lens to do these things, so you have to, so I think gonio technique, you have to watch a lot of videos first, know what you're looking at, and then you try as much as possible to get guidance from senior colleagues. When they place it, somebody should just, just look over somebody's shoulder, or if you are able, if you have in your center, you have this camera slit lamps, so that you can actually, with teaching aid, so that they can show you what they are looking at. Because a lot of times we mistaken some layers for others. I don't want to go to gonioscopy lecture.
Yeah.
So that's what I would say. 4 mirror gonio lens is a very good lens to use. Please.
Yeah.
Thank you.
Is there any role of von Herrick in management of patients with glaucoma?
Well, actually, to be honest, I don't know, but I haven't seen any studies showing that, but I think it's a good assignment for me. I'll also look at it.
Okay, thank you very much. Okay, we have just two questions left. One is for Dr. Guru, and the one in Q&A is for all of us to come together and give an answer to that. And the one for Dr. Guru is phasing and target pressure. You know, we have busy clinics. We have very busy clinics. We have a lot of patients to one glaucoma specialist. Is phasing feasible? Is it really necessary? Do we really need to phase patients within the context of our clinics and our time, our schedule? Is it something that we really can do in assessing target pressures for all our patients?
Well, it's possible. It's just to know how to do it for every patient, because when phasing, is it bringing in the patient and you check the pressure, just like what Dr. Kaba mentioned, or just for the target pressure? And since you have records for each patient, and at each visit, the intraocular pressure is taken, and then we follow up the patients with the fundus examination and with the field test. So it's something that we can do if we put our mind at it. And then if we have a structured follow-up for the patients. That is why it's important for us to have the protocol and the structured follow-up.
Okay, thank you very much.
So sorry, to add on that.
Yes.
Yes, Dr. Guru mentioned protocol, which is very, very important. There is also, and as you mentioned, yes, some centers might be having challenges in phasing all patients. So you can utilize the afternoon phasing, which I mentioned, actually in the clinics. So from 8 a.m. to 2, and then you can get that afternoon peak in most of your patients. And then that's one. Then secondly, there is the rule of thumb that some centers use, even actually abroad. So based on the cup disc ratio and nerve fiber loss, they try to target a particular pressure. So for example, a cup disc ratio of 0.8 and above, the target pressure of less than 12 millimeters of mercury. Then 0.67, the dance around mid-teens. For example, so 15 to 13. And then 0.5, 0.6, you can actually do the 16, 17, 18 millimeters mercury IOP. So some centers actually do have that, and it actually helps. And cup disc ratios of 1.0, you can target pressures of less than 9 and 8 millimeters of mercury. It actually works and maintains the nerve fibers for a very long time when you try to maintain pressure as low as 8 millimeters of mercury. Thank you.
Okay, thank you very much. Thank you very much. Okay, so the last question, and then I would have to, I'll be remiss if I don't recognize the presence of the OSN, GSN, Glaucoma Society of Nigeria incumbent president, Dr. Fatima Kyari, who is also the chairman scientific committee of the OSN. I would want to allow her join in and to opine on the last question, and also the past National Postgraduate Medical College Faculty of Ophthalmology president and Professor Adekoya is also here. She's also a glaucoma specialist with lots of experience. I also want her to join in and also give us an opinion on the last question. So just give me a few seconds while we enable. Okay, yeah, we have done that. Yeah, so good. So we've promoted into panels. Good afternoon, Dr. Fatima Kyari and Professor Bola Adekoya. We are elated that you found time to join us for our presentation today. I don't know if you're with us.
It seems Dr. Fatima is.
Good afternoon. Okay, so let's talk about the last question, because that's the last question before we sign out.
We have Professor Adekoya.
Yes, Prof, are you with us, ma? Okay, it seems they are not here with us, but they've been promoted to panel, so let's hope that they join with their opinion. We have somebody here with a question, a clinical scenario. If a young man with a family history of glaucoma, pretty large cup disc ratio, 0.7, 0.8, but visual fields are normal, the CCT is normal, OCT has some borderline abnormalities, and pressures are very low. Unfortunately, we don't have the refractive error status of this patient, so we'll assume the patient is an MHO. What should be done? Should this patient be commenced on medications? What are we going to do? What do we do for this patient? Family history of glaucoma, cup disc, normal visual field, normal CCT, some abnormality on OCT. We may want to think the patient may have pre-perimetric glaucoma, but would we start medications for this patient? Dr. Guruma.
Thank you very much. One, the OCT is, if OCT is changing, it has some changes, which is due to a defect, then that means one will need to start medication. Then the other thing is, for OCT, if the OCT is normal, then we'll say this one may be a physiological cupping, because I've seen large cups that are large and the OCT is normal. The field test is normal and the patient is being followed up for over 10 years and it's been stable. There is no progression or change at all. So, but if the OCT is abnormal, then that means this patient probably has a normal tension glaucoma, and we have to be started on treatment.
Okay, a little more information has been provided by the person who asked the question. The person said the patient has hypermetropic astigmatism and IOPs are 9 and 10. Are we still going to start treatment for these patients?
I will watch the patient.
Okay. Thank you very much, ma. Zero watch. Thank you very much, ma. Dr. Farouk, what would you do in this situation?
Yes, these are the kind of patients that I will be given the 3-monthly appointment. Very tightly.
Yeah.
So what you were mentioning earlier, because like I mentioned in my presentation, 5% of the population have cup disc ratio of 0.7 and more, which is normal. So this patient might be lucky to have normal large cup. So I will just follow the patient very closely. And if, like Dr. Ogura said, if I see any change on the OCT, which signifies non-fiber layer loss, then we discuss treatment option as soon as possible.
Okay, even with the family history, we'll still watch.
Yeah, yes, definitely, we watch.
Okay, thank you very much. We have more people joining us on panel. We are very lucky to have a lot of people from the Glaucoma Society of Nigeria, from the OSN. We have Dr. Fumi Ogun and Dr. Alice Ramil. Like I said, this is going to be like a kind of situation where the whole village is raising one child. So we want to have our opinions on this last question. I don't know if Dr. Fumi Ogun is with us. Dr. Fatima Kiari has sent. Hello, Dr. Fumi Ogun.
I'm with you, but can you repeat the question, please?
Okay, yeah, this is the question. The question is talking about a young man with a family history of glaucoma. His discs are pretty cupped, 0.7, 0.8, but the visual fields are normal. The CCT is normal. OCT has very little, some abnormalities, and his pressures are 9 and 10. The patient's refractive status is a hypermetropic astigmat. So the question is, do we treat or do we watch? And if we're going to treat,
what's the age?
I think he's mid-30s to 40s.
Is there a family history of glaucoma?
There is a family history of glaucoma.
Okay. Well, personally, I am not, because you have to remember that glaucoma is treatment for life. I personally am not quick to jump to such diagnosis. I would watch and follow him closely. In fact, I could invite the patient back in a month, look at the difference in the field and the investigations, do it again in about 3 months, 2 months. I will follow closely because he has a whole life ahead of him. You subject him to, and in fact, you will be surprised that the no problem of 9 and 10. What if he starts developing early signs to show that he has a pituitary, tumor or something? So I don't jump to treat. And never, you have to remember that glaucoma is not just a sight-threatening disease, but it's something that affects the quality of life. Even when you are successfully treating with medications, with procedures, it affects the quality of the patient's life. And it has impact, not just on the patient, but on those around him. So the most important thing is the care and the follow-up to prevent unnecessary vision loss. Because even with the best treatment, you will still have some degree of vision loss. So it is that vigilance that is the best thing that you can do for a patient. That's my.
Thank you very much, Ma. I don't know if Professor Bola Adekoya is with us now. Okay, I think she's still not with us. So I think the consensus is that we would watch and then follow up the person, while we'll keep a tight leash on the patient and watch. And at the slightest indication of progression or development of new OCT changes or visual field changes, we would treat immediately. So I think we've had a very robust discussion on evaluating a patient with glaucoma and setting a target pressure. This is the first of our glaucoma series for the year, and thankfully it fell just within the World Glaucoma Week. We'll have our next glaucoma series in about 3 months, and we, just like we did last year with the cataract series, we hope to conclude the glaucoma series this year and begin a new series next year. I want to thank our panelists, both our impromptu panelists and our scheduled panelists. We want to thank you very much for coming to join us, even though at short notice. It's always very fun and interesting to learn from experience, because even though we read a lot of books and watch a lot of videos, experience still counts. So I want to thank you very much for joining Young Ophthalmologist Forum. We are happy to see our elders encouraging us and showing us what we should do when we get to their state. So we're thankful for joining us, and we hope that the support will continue. And before I go, I would like the organizer of the YOS World Glaucoma Week to please say some words. Dr. Ibukun, I hope you're with us. Yes, please.
Good morning, everyone. It's been an exciting and activity-packed 1 week to celebrate the World Glaucoma Week. I want to say a very big thank you to all who joined us during the program by sharing posters to raise awareness on glaucoma. Our resource persons who went to radio stations and television stations to talk about glaucoma. All our panelists for the 3 different real-time events we had. I say a very big thank you to you. God bless you. And I hope the lecture today, we've learned a lot, so many things said, and I hope this will impact our practice. We'll put them into patients.
Thank you very much for the last time. I know I keep saying thank you, thank you. That's all I can say. Thank you very much for joining us. Thank you for helping us out.
We also like to appreciate some of our colleagues from KSA and United Kingdom. Thank you for joining us.
This is the end of the World Glaucoma Week for the YOF and for the year of glaucoma care, and to bring knowledge of ophthalmologists are the generals in fighting blindness in Nigeria. Thank you very much once again, and have a great day ahead.